you're sitting there in that freezing cold, sterile testing center, and the NCLEX timer is just like visibly ticking down in the corner of your screen.
Oh, yeah, the ultimate stress test.
Exactly. And suddenly you're hit with this massive block of neuro questions, specifically all those ones about dementia and Alzheimer's disease. And the panic just completely sets in.
Because you're frantically trying to recall all those arbitrary stages and the weird medication mechanisms, right?
Yeah, and those highly specific behavioral interventions, it usually just feels like this overwhelming mountain of sheer memorization. And it feels totally disconnected from, any real human being.
Well, I mean, that disconnect happens because textbook descriptions, they rarely capture what physical brain failure actually looks like when you are physically standing in a patient's room.
Right. Reading a bulleted list of symptoms doesn't exactly prepare you for the emotional weight of it.
No, not at all. Or the physical reality of the disease process.
Which is exactly why we are changing the approach today. Welcome to an episode of the Super Nurse Podcast, created by Brooke Wallace.
Absolutely.
Now, a quick disclaimer right out of the gate here. I am not Brooke Wallace, but this entire conversation is built directly from Brooke's 20 years of hard-won bedside knowledge.
Yeah, she brings so much experience.
She really does, as an ICU nurse, an organ transplant coordinator, a clinical instructor, and a published author. We are utilizing her personal notes and her specific teaching style to help you.
Meaning you, the listener, whether you're a nursing student or a new grad.
Exactly. We want to help you take those abstract concepts from school and actually apply them to real physical patient care.
And before we get into it, we highly recommend you subscribe and watch the video version of this show on YouTube.
Yes, definitely do that.
You can find the link right in the description on our channel, which is called Super Nurse AI.
Okay, so to really care for an Alzheimer's patient and to confidently answer those psychosocial integrity and basic care and comfort NCLEX questions, we have to shift our mindset.
Right. We have to stop treating this as just like getting older.
Yeah, or just normal forgetfulness. We need to talk about what is physically, structurally breaking down inside the skull.
Well, the foundational concept you need to grasp is that Alzheimer's is a progressive chronic brain disease, and it results in the literal death of neurons.
Like actual cell death.
Yes. And clinical research points to two main physical culprits that cause this destruction. They basically attack the cell from two different directions.
Okay, break that down for us.
So first, you have beta amyloid plaques. You can think of these as sticky clumps of protein debris that build up outside the neurons.
Outside the cells, got it.
Right. They sit in the synaptic spaces between the cells and act like basically impenetrable cement roadblocks. They completely stop the electrical signals from jumping from one neuron to the next.
Wow, okay, so while those plaques are causing a total communication blackout on the outside, there's a second culprit destroying the cell from the inside, right?
Exactly. And those are called neurofibrillary tangles.
Such a mouthful.
It really is. But think of it like this. A healthy neuron relies on this beautiful internal highway system made of microtubules to deliver nutrients up and down the cell.
Okay, I'm with you.
And a specific protein called tau acts like the railroad ties holding that whole highway together.
But in Alzheimer's, that tau protein just chemically breaks down.
Yeah, it falls apart and it clumps together into those tangles, so the structural highway just collapses. The cell literally starves to death from the inside, and then it dies.
That is so wild. And the clinical consequence of millions of these cells starving and dying is profound brain atrophy.
Yes, the brain physically shrinks.
It shrinks. And at the same time, the chemical environment in there becomes incredibly toxic. The brain experiences this severe drop in a neurotransmitter called acetylcholine.
Which is super important.
Yeah, it's the primary chemical we need for memory formation and learning. But simultaneously, there's a massive excess of another neurotransmitter called glutamate.
Right, and in normal amounts, glutamate is totally helpful.
But in these massive floods, it becomes an excitotoxin.
Yeah.
It literally overstimulates the remaining healthy neurons until they just burn out and die.
It's just chemical chaos.
It really is. And understanding that chaos makes the pharmacology make so much sense. Like when a provider orders cholinesterase inhibitors, like donepezil.
Right, they're just trying to stop the breakdown of whatever precious acetylcholine is left, just to temporarily boost that memory function.
Exactly. And when they order NMDA antagonists like memantine, they are trying to block that toxic, burning flood of glutamate.
That's spot on. Brooke actually uses a great visual analogy for this overall structural damage.
Oh, the tangled wire.
Yes, she tells new nurses to imagine a drawer completely shoved full of tangled electronic wires. When you try to pull one wire out, no matter how gently or, logically you pull, the knot just gets tighter.
The connections in the Alzheimer's brain are permanently knotted.
Exactly.
But, my human instinct, especially when I was much newer to the bedside, I often pushed back on this idea of permanent damage, mainly because of how the patients act.
Oh, I know exactly what you mean.
Right, because you will see a patient be perfectly articulate, charming, and totally cooperative with the attending physician for like 5 minutes during rounds.
They look totally fine.
But then the second the doctor leaves the room, that same patient is screaming at you or accusing their daughter of stealing their wallet. It feels incredibly manipulative.
It really does. It feels like they are choosing when to behave.
Yes. Why does it feel like they're faking it?
Well, that feeling is actually one of the most common frustrations for both newer nurses and grieving families. But what clinical experience reveals here is a phenomenon called the social reflex.
The social reflex, okay.
Yeah. The human brain has these deeply ingrained automatic reflexes for how we act around authority figures or strangers or doctors.
Like putting on your best face.
Exactly. When the white coat walks in, that survival reflex kicks in and temporarily overrides the cognitive damage. The patient pulls it together, they smile, they answer questions.
But doing that requires a massive, totally unsustainable amount of mental energy, right?
Oh, huge. They are basically redlining their brain's engine just to maintain that mask for a few minutes.
And when they are back with familiar people like their family or their primary bedside nurse, they just can't sustain the performance anymore.
Precisely. Those social reflexes drop, their guard comes down, and you see the unmasked, true extent of the damage to the frontal lobe.
And the frontal lobe is basically the boss of the brain.
It is. It handles reasoning, impulse control, and emotional regulation. So when that mask drops, they lose all of those filters.
So they aren't manipulating you at all.
No, not at all. They just no longer have the cognitive stamina to hide the structural failure of their brain.
That makes so much sense. So if the frontal lobe is taking the brunt of this damage early on and executive function is just collapsing, that's going to manifest in very specific ways when we are trying to provide basic care.
Oh, absolutely. This is where we see those famous A terms that the NCLEX loves to test so heavily.
But instead of just defining them like a textbook, let's look at how they actually derail a simple morning routine at the bedside.
Let's do it.
Okay, let's say you hand a patient a toothbrush. They have the physical muscle strength in their arm, but their brain simply forgets the sequence of movements required to bring it to their mouth and brush.
Right. And that specific mechanical failure is apraxia. It is the inability to perform basic motor tasks despite having completely intact motor function.
And the disease compounds on itself from there.
It does, because the patient might look at that toothbrush in your hand and have absolutely no idea what it is or what it's used for. The brain can no longer interpret the visual input.
And that is agnosia, right?
Yes. Agnosia is the inability to recognize everyday objects or, tragically, even familiar people.
Man. And then you try to explain it to them verbally, but they just stare at you blankly, or they try to respond, and the words come out as a jumbled, nonsensical mess.
Which brings in aphasia, the inability to understand or form speech.
It's just barrier after barrier.
Yeah. And even if they can still speak relatively well, they might experience anomia.
What does that look like?
Well, they know what the toothbrush is, they know what it does, but they absolutely cannot pull the specific word toothbrush from their brain's filing cabinet. They might call it a mouth stick, or just get incredibly frustrated.
And seeing a patient get frustrated like that often triggers our instinct to try and fix the problem using logic.
Oh, always. We want to explain it away.
Let me throw a classic bedside scenario out there. You walk into a room, and your patient is frantically tearing their belongings apart. Instinct is to step in and reassure them. I want to say, hey, it's okay, calm down. Your poos isn't here, we'll find it. But trying to logic them out of that panic seems to consistently backfire.
It does.
Why does the phrase calm down escalate the situation so incredibly fast?
Because you are attempting to negotiate with a broken logic center. When you say, calm down, the purse isn't here, you are using objective reality to completely invalidate their subjective reality. To the patient, the missing purse is a genuine life or death emergency. Their brain is sounding a massive alarm.
So when you invalidate that alarm,
You trigger extreme defensiveness, deep shame, and just overwhelming anxiety. What the evidence tells us about dementia care is this core principle: emotion is comprehension.
Emotion is comprehension. Let's really unpack that because it feels like a total paradigm shift for nursing communication.
It is a shift. Because their ability to decode your actual vocabulary is failing due to that aphasia, they essentially stop listening to your words.
So what are they listening to?
They rely almost entirely on your tone of voice, your facial expression, and your body language. If you walk into that room with this rushed, dismissive energy, sighing and saying, calm down, they don't process the reassurance.
They just feel the rush.
Exactly. They only process the dismissive, hurried energy, which their damaged brain interprets as a direct threat.
So if their reality is driven entirely by what they feel and perceive in the moment rather than logic, we have to completely adapt our nursing interventions.
We really do. We cannot expect them to conform to a standard hospital schedule.
And this is heavily tested on the NCLEX under the basic care and comfort category, right?
Yeah.
Particularly around nutrition.
Oh, absolutely. Patients with moderate Alzheimer's experience severe restlessness. They pace the hallways constantly.
Trying to make them sit at a table for a 30-minute meal seems virtually impossible.
It is. The combination of that severe restlessness plus the apraxia and agnosia we just discussed means sitting down with a fork and knife is just a setup for failure.
Because they forget how to use the utensils.
Right, and they lack the attention span to stay seated anyway. So the highly tested nursing intervention here is that we must closely monitor food and fluid intake to prevent malnutrition and dehydration, but we have to do it completely on their terms.
So what's the practical bedside solution?
Offering high-calorie finger foods. You provide items they can physically hold in their hands and eat while they're pacing around.
Okay, that makes sense. And another layer to that is limiting the visual options, right?
Yeah.
You only offer one food item at a time.
Yes, exactly.
See, in nursing school, the concept of patient autonomy is drilled into our heads. We are taught to empower our patients. So if a patient needs to eat or get dressed in the morning, my instinct is to ask an open-ended question to give them control.
Like, what do you want to wear?
Yeah, I want to ask, what do you want to wear today? Or what would you like for lunch?
And while the intention behind promoting autonomy is excellent, using open-ended questions with a dementia patient is actually a major clinical trap.
Really? Why?
Because open-ended questions require a massive amount of executive functioning. The patient has to search their memory for options, sequence the steps of answering, and form the correct words.
Which their frontal lobe can't do anymore.
Right. For a brain with severe frontal lobe damage, asking what do you want for lunch causes immense cognitive overload. It leads to decision fatigue and, very quickly, severe agitation.
So how do we maintain their dignity and autonomy without overwhelming that broken logic center?
Clinical experience shows we achieve this through binary, forced choices. You hold up two items and ask, would you like the red shirt or the white shirt?
Ah, would you like soup or a sandwich?
Yes. You are still providing them with control over their life, but you are removing the crushing burden of infinite choices.
Limiting choices is really about limiting sensory input, isn't it?
Basically, yes. The damaged brain simply cannot process multiple streams of stimuli at once.
If a dinner menu causes cognitive overload, a noisy hospital room or a chaotic living room is going to do the exact same thing.
Without a doubt, which is why environmental interventions become a massive priority. We have to minimize noise and distractions, especially during meal times.
That means turning off the television, shutting off the radio, and decluttering their immediate line of sight.
Exactly. Managing the environment is also the cornerstone of patient safety, which is paramount on the NCLEX.
Right, because their spatial awareness deteriorates.
Yeah, so you have to hide door locks out of sight to prevent dangerous wandering outside the home. And, highly tested, you must remove scatter rugs. Oh, the scatter rugs.
Yes. As the disease progresses, their physical gait changes. They lose the ability to pick their feet up normally, and they begin to shuffle.
And a scatter rug in the path of a shuffling patient is a guaranteed fall.
100%, which is why it shows up on nearly every nursing exam.
It's such a classic NCLEX trap. Now, when we talk about managing this environment and adjusting our communication, we aren't just doing this in a vacuum. Caring for the Alzheimer's patient inherently means we are caring for their family.
That is so true. It's a package deal.
Right. Under the psychosocial integrity umbrella, we are dealing with families who are exhausted, burned out, and experiencing profound, ambiguous grief.
It's heartbreaking to watch your loved one slip away while they are still standing right in front of you.
It really is. So the nursing role shifts heavily toward education and care planning. A crucial intervention is facilitating discussions about healthcare decision-making early in the disease process. Very early. We need to assist the family in establishing advanced directives and goals of care while the patient still has enough cognitive reserve to express their own wishes.
Because that window of lucidity closes permanently
Yeah.
and you don't get it back.
You really don't.
And the big piece of that family education is teaching them how to communicate without causing unnecessary pain. We have to teach families the validation over correction technique.
This is such an important bedside skill.
Going back to an earlier example, if a patient is wandering the halls saying, "I need to go visit my mom," the family's instinct is often to ground them in reality. They might say, "Mom has been dead for 20 years, you can't visit her."
And correcting their reality with logic forces the patient to process the death of their mother all over again, as if they are hearing it for the very first time.
Oh, that's brutal.
It is. It causes fresh grief, deep confusion, and usually aggression toward the person delivering the news. Teaching validation over correction means teaching the family to validate the emotion driving the statement rather than the factual inaccuracy.
So you just say, "You must be missing your mom today. Tell me a story about her."
Exactly. You connect with their emotional reality instead of forcing them into yours.
We also need to help families drop the long, drawn-out explanations. Giving a multi-step logical explanation to an Alzheimer's patient is, it's like handing a 1,000-piece puzzle to a teenager you just abruptly woke up from a deep sleep.
That is a perfect way to describe it.
Their neurological processing speed is just way too slow to catch up, and they're just going to get frustrated and angry at you.
Right. So we encourage families to use short, simple sentences and to employ the you plus me framework.
How does that work?
Well, a command like, "you need to go take a shower right now," feels isolating and threatening. But shifting the language to, "let's go freshen up together," creates a sense of partnership and safety.
I love that. Let's go together. But the family dynamic is so tough because caregivers at home are often living in a constant state of low-grade panic.
Oh, the caregiver burnout is very real.
They're trying to get to appointments, manage medications, and keep their loved ones safe. But rushing a dementia patient triggers their biological fight, flight, or freeze response.
It does. Every single time.
We have to actively educate families that slowing down your physical movements and the cadence of your speech isn't being inefficient.
No, not at all.
Slowing down is a vital, deliberate clinical intervention required to regulate the patient's nervous system.
And anticipating those changes becomes even more critical as the disease enters the final stages. Eventually, the structural damage isn't just affecting the outer cortex or the frontal lobe. It progresses deep into the brain.
Eventually hitting the brainstem.
Exactly. And the brainstem controls the automatic, involuntary functions of the body, things like breathing, heart rate, and swallowing.
And at this point, the goals of care drastically shift toward hospice and palliative care.
Yes. Understanding the trajectory of this decline helps manage family expectations. The disease progression doesn't look like a smooth, predictable ski slope of steady decline.
It's more like a staircase, right?
Exactly like a staircase. The patient will plateau for months at a specific baseline and then experience a sudden, sharp drop in function.
And those drops are usually triggered by an acute physiological stressor, right?
Right.
Like a UTI or a fall.
Yeah, or even a mild respiratory virus. They step down a level, the infection clears, but their cognition never quite returns to that previous plateau.
And in the late stages following those drops, the clinical picture is characterized by the patient becoming entirely bedbound, nonverbal, and completely incontinent.
And a major defining feature here is severe dysphagia. Because the brainstem is heavily damaged, they literally lose the mechanical motor memory of how to swallow.
Wow. So at the bedside, you start noticing them pocketing food in their cheeks.
Right, they just hold it there.
They cough during meals and experience frequent choking episodes, which inevitably leads to a very high risk of aspiration pneumonia, where food or fluid actually enters the lungs.
And aspiration pneumonia is, tragically, one of the leading causes of death for patients with end-stage Alzheimer's.
The role of palliative and hospice care becomes vital here because the medical goal shifts entirely away from curative treatments or prolonging life and focuses strictly on maximizing comfort and preserving dignity.
Yes. And a major hallmark of this final stage is that patients will naturally stop eating and drinking.
Which is so hard for families.
It's the hardest part. We have to educate families well in advance, if possible, that this is an expected biological part of the dying process.
Because watching someone stop eating goes against every instinct we have as human beings,
Yeah.
and certainly everything we are taught as nurses about preserving life.
It feels wrong.
How do we explain this clinical reality to a terrified family member who is standing at the bedside, begging us to put in a feeding tube or force feed their loved one?
It requires deep compassion paired with clear clinical truth. We have to gently explain the mechanism of what is happening. The patient isn't dying because they are starving. They are not eating because the body is actively dying.
The organs are shutting down.
Exactly. The body no longer requires metabolic fuel, and more importantly, it has lost the physiological ability to process that fuel.
So feeding them would actually cause harm.
Yes. If we force food or IV fluids into a body that is actively shutting down, it doesn't reverse the dying process. It causes fluid to back up into the lungs, induces respiratory distress, increases swelling, and ultimately causes more pain.
The core nursing priority at the very end of life becomes incredibly simple yet profoundly important. Keep them clean, keep them safe, and keep them comfortable. We have to allow the physical body to dictate the timeline.
Truly.
When you look at this entire clinical picture, from the initial structural damage blocking the synapses to the final involvement of the brainstem, it all comes down to adjusting our reality to meet theirs.
And that is exactly what the NCLEX is testing your ability to do. It wants to see if you can trace the physical pathology to the behavioral outcome, and then choose an intervention that respects that damaged brain.
Let's make sure you walk away feeling empowered rather than intimidated by these narrow concepts. Alzheimer's is permanent, physical brain destruction, not a behavioral choice.
It's not a choice.
Remember that emotion is their primary language, so always validate the feeling rather than correcting their facts. At the bedside, monitor their intake safely by offering one finger food at a time, limit decision fatigue by using binary choices, fiercely protect them from sensory overload, get rid of those scatter rugs, and ensure end-of-life care is entirely focused on comfort.
There's one final overarching concept we need to leave you with today. It's the mechanism that makes all of these interventions actually work, and it's called co-regulation.
Co-regulation. This is the aha moment that really changes how you practice.
Because the Alzheimer's patient has literally lost the physical brain tissue required to regulate their own emotions and soothe their own anxieties, they have to borrow yours.
They borrow your nervous system.
Yes. Human beings have mirror neurons. When you walk into a patient's room, their autonomic nervous system is subconsciously scanning your autonomic nervous system.
So if you walk in, anxious, rushed, holding your breath, and stressed about your other 6 patients,
Their damaged brain mirrors that frantic energy instantly. It registers your stress as a biological threat, and they will become agitated, combative, or fearful.
but the reverse is also true. And that is where your power as a nurse lies.
Exactly the reverse. If you take 3 deep breaths before you open that door, drop your shoulders, lower the pitch of your voice, and walk in calm, grounded, and centered, their nervous system will mirror that safety.
Their breathing slows down because your
Yep.
breathing is slow.
Yes, because they cannot regulate themselves. Your physical presence, your stability, and your calm energy literally become their medicine. You are a walking, breathing clinical intervention.
Your nervous system is their medicine. What an incredible way to look at our impact at the bedside. Thank you for joining us for this conversation. Remember to head over to watch the video version of this on YouTube, hit that like button, subscribe, and leave a comment.
And be sure to visit supernurse.ai for amazing resources.
Yes, tools to help you become the super nurse you are born to be. See you next time.